pleasure to it's giving me a great pleasure to introduce our speaker for tonight, Dr. Khalid Al-Rabia. He's a consultant radiation oncologist at King Faisal Specialist Hospital and Research Center. He did his residency and fellowship in GI oncology. Dr. Khalid.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Dr. Abdullah. It's a great pleasure and honor to be with great colleagues and mentors in this session. Thank you so much for this invite to speak about the evolving role of radiotherapy in the management of liver cancer. So the outline of this presentation will include a review of current evidence of radiation role in treatment of HCC as a curative treatment, as a bridging to transplant modality, as its role with current systemic therapies, and we'll touch slightly on role of proton therapy, especially with the exciting news about the introduction of proton in our country. And then we'll review the role of radiotherapy in treatment of liver metastasis, followed by a small touch on planning workflow of this technique. So before going into these data, seeing the incidence of liver cancer in Saudi, this is this shows the numbers in 2020, and you can see 2 points here. Liver cancer is not a rare cancer. It is common, probably not as common as colorectal or prostate or breast, but it is there. And the second thing, males are by far more frequent to have this type of malignancy compared to females. Second thing, before going into the data about treatment of HCC, is touching on this very important publication. One cannot speak about HCC without reviewing the Barcelona Clinic Liver Cancer Treatment Guideline. This is the most recent of these guidelines, published in 2022. And this figure summarizes it all with staging from very early up to terminal stage, and then the diagram about treatment and the modalities to be used. But there is a major thing that is missing in this diagram. We're going to see it at the end to see what this thing is, what its role. Yes, spoiler alert, it is the topic of this presentation. Before going into recent data and new techniques, while I was looking for the reports on patients treated with liver SBRT, I noted this nice publication in 1995 from this group. This is considered the first report of patients treated with liver SBRT, published data we're speaking. And they nicely describe their radiation therapy technique, how they used CT, MRI, and PET scans, combined those modalities, how they did motion management, how did they do abdominal compression, how did they deal with uncertainty. A lot of thought they put into this treatment before trying it, and it's really a nice paper to read. The table that gets my attention is especially this table from that paper. Shows those numbers are the numbers of patients. So patient number 5, number 7, number 8, and number 10. See number 5, for example. this patient with HCC, they treated with a dose that ranges from 30 gray to 51 gray, of course, taking consideration the heterogeneity. And this was one fraction only. And like this is a very high dose, but this is the first report. Those reports shows us what good doses, what good outcomes, and what not. Patients died, unfortunately, 2 days after radiation, so probably grade 5 toxicity. Other patients have had really nice control of their disease, but very courageous doses to use at early time of using this technique. Some patients develop toxicities. What about modern data? This is a nice report analysis of two clinical trials, phase 2 clinical trials. Both combine 102 patients with active HCC and the following criteria. So all patients had child PO of A, with at least 700 cc's of non-HCC liver. This number, we see it a lot. Where do we get it from, and how did it come into the radiation oncology literature? People speculate that this came probably from the surgical data. Hepatobiliary surgeons, before they do surgeries, they estimate how much normal liver they leave for the patient to have a functional and liver and not to decompensate. Their literature ranges probably from 25 to 30%. If you see a liver and calculate this volume, probably translates into 700, 800 cc's. So prior therapies were allowed in those patients. Tumor thrombosis was allowed as well, a very bad prognostic factor, we'll see later. No more than 5 liver tumors were allowed, maximum dimension of 15 centimeter, and that size and number is a pattern that's going to continue on subsequent trials with slight modification. Extrahepatic disease was allowed, but only if liver has the greatest burden of disease. Those ranged from 30 to 54 grays. All patients received those in 6 fractions, and those were on alternate days, so day on and day off. Their results shows very good local control of about 87% at 1 year. They didn't notice classic radiation-induced liver disease. In patients without progressive disease, a decline in child Turkitt post class was seen, about 29% at 3 months and 6% at 12 months. There was significantly higher median liver dose in patients who developed grade 5 toxicity compared to those who did not. The difference is minimal between them, but is major, especially at high child PO score. The diagrams on the right side of this slide, let's start with the bottom one, for example. You can see the effect that tumor thrombus have on prognostication of overall survival and on those patients. Those with no thrombosis did much better. And then see the effect of those on probability of local recurrence. Generally, we think that radiation dose, the more it is, the higher the chance of control and the less probability of local recurrence. This was not seen in this analysis, even though the two lines separate, but it didn't reach statistical significance, probably showing how sensitive this disease is to radiation. Who of those patients had better local control and overall survival? A major thing is tumor vascular thrombus, especially macrovascular thrombus at major vessels like portal vein, for example. This really affects overall survival, especially. And then the minimum dose to PTV effect. only on univariate analysis on local control. It didn't reach significance on multivariate analysis. Toxicity-wise, grade 3 toxicity was about 26.5%. Considering this report studies the toxicities and studies the role of radiation using those high doses. These are not bad results. There was grade 5 toxicity. There are multiple ways to avoid it, taking consideration especially at patient general liver function and tailoring the dose based on that. What predicted toxicity in SBRT and HCC? Portal vein thrombus. So this portal vein thrombus affected the prognosis of the patient and affected the chance of toxicity. It's important to note that portal vein thrombus here is meant to be tumor thrombus. So bland thrombus that some of these patients have is not part of this thrombus definition here. Their baseline child post score had a major effect. Even between child of A to 6, there was a difference. We'll see later. Baseline platelet count had an effect. So lower, so platelet count have an effect in toxicity, and it's something that must be noted in when treating those patients. Mean liver dose and be effective as well. They also did a nice model of biological normal tissue complication probability and correlated that with toxicity. D800 cc's, there was major effect on toxicity, even with 0.1 gray increase. So speaking about child PO score, so they included child PO of A. So in A, we have A5 and A6. One would not expect that there will be lots of difference with radiation toxicity, but the truth is that there is. If you see the diagram, the upper one on the right, you see the line of A6 having higher chances of complications at even low doses of mean liver of 10, or that reaches even more significance at 15 and higher. Where in A5, you require higher doses than A6 to reach that level. The lower diagram tells us the details of the upper one. It describes the chance of having toxicity correlated with the dose overall. The differences in toxicity maximized at the following cutoffs with their analysis: mean liver dose of less than 20 gray and D800 cc's of less than 15 gray. This is when speaking about A5 and A6. One of the greatest diagrams that they present in this analysis is this table. Correlating D800 cc's and mean liver dose. So those two factors were one of the most factors they correlated with toxicity. Now, how do we correlate those two factors together when we do plans for patients with SBRT? Green is great. Green means chance of toxicity is very low. Then the higher the numbers, the darker the small pixel, the higher chances of toxicity. It's a great table to quote patients' chances of toxicities with the doses that they receive after doing the planning. But one should note that this correlates with 6 fractions regimen. So role of liver SBRT. was being studied in phase 2 trials or single-arm trials until 2022. This really landmark trial, probably the most major trial in radiation oncology in HCC literature, RTOG 1112, randomizing patients with locally advanced hepatocellular carcinoma to either sorafenib, which was the standard of care at that time, versus SBRT plus sorafenib. So there was resistance about involving SBRT in treatment, and the role of this trial was to prove that compared to systemic therapy alone, SBRT can improve outcomes. They included patients with locally advanced HCC and suitable for RFA or TACE, or had a recurrent post-resection disease. All patients were child of A. Platelets correlated with toxicity, so they required a platelet of higher than 60. Some liver was less than or equal to 20 centimeters and less than 3 HCC foci. They also included vascular invasion. This is their randomization, and they had multiple stratifications we're going to see later. There was indeed overall survival benefit with SBRT. So this established a new standard of care at time of publication of this trial, and a very good argument in using this trial in tumor boards when trying to argue with interventional radiologists, for example, about the role of SBRT compared to their modalities. So the variables that they included performance status. Of course, as most diseases, the better performance status, the better the outcome. Patients who had metastasis did not do as well as those who did not. Go to the lower part of this table and correlate it with M-stage. So macrovascular invasion had almost similar hazard ratio as M-stage, and both were statistically significant, which tells you really that macrovascular invasion is a bad prognostic features in those patients, but does not prevent us from treating HCC. Child post score, again, A5 better than A6. At time of publication of that trial, or preparing that trial for publication, RTOG 1112, another trial came just probably 1 month or 2 months published before it in New England Journal of Medicine, establishing new standard of care for systemic therapy at time, and this trial compared it to atezolizumab. Primary outcome was overall survival, and they did have a statistically significant overall survival advantage, as well as improved progression-free survival. So at time of those two data being present, new standard of care for systemic therapy, and then SBRT being compared to the old sorafenib in treatment of SBRT. How do we see the role of SBRT now with those two trials? To speak about that, one should see the characteristics of patients who were involved in this New England Journal trial with atezolizumab versus sorafenib. So there was presence of extrahepatic disease more than RTOG 1112. Extrahepatic disease here reaches up to 63% in the arm of atezolizumab. And then you see the patients who have, for example, autoimmune diseases like autoimmune hepatitis, who are not eligible for this for this immunotherapy, or who would medical oncologists hesitate to give. These are patients who probably would be, when they receive sorafenib, one should suggest SBRT to be combined with. So low extrahepatic disease burden, and those, for example, with autoimmune disease, or patients with sorafenib plus SBRT, because let's remember, it wasn't compared head-to-head to atezolizumab in a trial. When this immunotherapy trial came out, multiple reports came to see the role of SBRT plus immunotherapy, and this is one of them. Most data now are retrospective. Multiple prospective randomized trial are being conducted, but we have retrospective data like this one that shows us probably improved overall survival. That is significant. The caveat here is this is retrospective data. It has multiple biases. And here compared SBRT immunotherapy versus SBRT alone, where the model that would hint toward SBRT benefit in presence of immunotherapy would be a model like SBRT plus immunotherapy versus immunotherapy alone, like RTOG 1112, to reestablish the role of SBRT in the presence of immunotherapy, or to introduce it to immunotherapy treated patients. Now, we saw RTOG 1112 and the improved overall survival with sorafenib. So what if we use sorafenib plus interventional radiology procedure, say selective internal radiation therapy, versus sorafenib alone? Would that interventional radiology procedure gives us overall survival? I know we cannot compare trials to each other, different patients, different things, but it gives us like sometimes just an insight, or it's good just to see them, but not to compare them directly, of course. So this trial, ceramic clinical trial, more than 200 patients with advanced HCC randomized to selective internal radiation therapy plus sorafenib versus sorafenib alone. Median overall survival was not changed. RTOG 1112 had statistically significant overall survival advantage, but again, remembering we cannot really compare trials that has different selective criteria. So SBRT is good and it gives us good overall survival in those patients, but does it really gives us durable response for a long time? This is a report of few patients who were followed long-term to see the effect of SBRT on their treatment. One of them is this 39-year-old male patient with hepatitis C, HIV, and a child post-score of A5. His CT scan, a screening CT scan actually, that was, if I remember well done, probably for some abdominal pain, showed signs of HCC. So you can see in baseline scans on the diagram on the left, an arterially enhancing images, as well as venous washout on A2, and you can correlate that with the MRI. There is a macrovascular invasion that is clear on the scan of the portal vein at baseline. We said that this is a very bad prognostic factor. His alpha-fetoprotein was more than 1500. He was not eligible for transplant. Milan criteria and San Francisco criteria for transplant exclude those patients with major vessel invasion, and some exclude also those, for example, with infection like HIV. This patient was treated with SBRT 35 grays in 5 fractions plus sorafenib. His alpha-fetoprotein normalized to result of 2. You can see 6 months follow-up scan in B1 and B2 and compare them to the initial disease. Patient had a good local control until about 4 years, specifically at 73 months when disease recurrence was noted. At that time, he was retreated with SBRT at a dose of 27.5 gray in 5 fractions alternate days using MR-Linac plus lenvatinib. He had later on toxicity from lenvatinib, so it was stopped. Patient died 10 months after second SBRT, but 83 months control of disease shows us how good SBRT is if delivered to HCC, even at doses of 35 and 5 or 27.5 and 5. These two are the plans for this patient. The one on the left is the Linac based SBRT with 35 grays in 5 fractions. The one on the right is the MR Linac guided treatment at time of recurrence with 27.5 gray in 5 fractions. A really great modality and treatment of patients with HCC, especially those who sometimes have ascites. We know those patients have sometimes ascites. They change from day to day. With MR-Linac, really the machine takes into account of that separation change and gives you plan change at each fraction with slight modification probably of the contour and organs at risk. Hopefully we have it in our country sooner rather than later, inshallah. What about comparing interventional radiology procedure like TACE, for example, to SBRT in patients who are planned for local control improvement or who are planned as a bridge to transplant patients. This trial did that. It didn't accrue very well, as most of these trials that combines 2 modalities. No one wants to have the chance that their modality is worse than the other. But nonetheless, they accrued 30 patients in each randomized arm. SBRT was delivered 6 fractions, 8 to 9 gray. Delivered once only, where if you see TACE, they had a max of 4 TACE procedures and ablation after incomplete TACE. So this tells you like the burden on the healthcare system, as well as how many times the patient can come in, and then the chance of decompensation. Well, SBRT is delivered once, and their primary endpoint was time to progression. Their results shows SBRT was the clear winner. Of course, low number of patients, so one cannot get really definitive answer. But this correlates with multiple reports of SBRT having a much better local control to other interventional radiology procedures, including TACE, including RFA, especially in disease which is larger than 3 centimeters in size. You can see also when they censored patients without of liver transplant candidates who usually probably have sometimes less Child-Pugh scores. Even at that point, SBRT was better in local control. Overall survival, there was not much difference between both modalities. So bridging to transplant, something that is commonly used for patients who are being considered for transplant. Some institutions use Milan criteria, some use San Francisco criteria. when those patients reach or are at the edge of reaching the size criteria, for example, or the number criteria to be excluded from transplant lists, they are usually presented in tumor boards and or sent to other specialties, most of the time interventional radiologists, sometimes to us in radiation oncology, to consider treatment and decrease the burden of disease, to keep the patient on the list as much as possible until transplant candidate with similar factors is only those patients, and gave them either SBRT or TACE. Again, small number of patients. They planned for 60. 29 of them were within Milan criteria. They randomized those 29 into two arms, SBRT versus TACE. SBRT was given at 45 grays and 5 fractions, which is a common dose used in bridging to transplant patients and those who are child PO of A, for example. This dose should decrease in those who have lower or worse child PO scores. You can note it, like two things takes my attention here in those two tables on the right side of this trial. See the hospital days. For example, day 2. TACE patients, 86% of them were hospitalized day 2. Day 1, we see 100% maybe in SBRT. Probably in this trial, they required their patients to stay in day 1 or something like that. But day 2, 0% of patients. None of them came back to the hospital or were hospitalized only for 1 day, where TACE patients hospitalized more than 1 day is a higher chance. Time to retreatment. CSBRT 0, 0, 0, and 0 from 3 to 12 months. Where in TACE, the numbers increases as time increases. So proton, soon, inshallah, there will be access to proton therapy here, and this is very exciting news, and it will probably help the HCC patients as well. This retrospective data, including large number of patients, published in the Red Journal, shows benefit of proton therapy in probably improving overall survival in those patients and decreasing the risk of having radiation-induced liver disease. Of course, when we see retrospective data, we think about all the biases it can have. We think about all the flaws that this can have. But this stimulated people to come up with trial like this one, NRG GI 003, that randomizes patients to either proton or photon treatment. Will be interesting to see, and the primary outcome is overall survival. With the previously mentioned data and multiple data that is available other than what is presented, guideline is needed. And this is a nice publication. It says on the top of the slide, publication February 1st, 2024, in 2 days. Probably as a print version. This is the online version. So SBRT for HCC meta-analysis and international SRS society practice guidelines. They aggregated data from multiple studies and trials. They put their data and which location and what is the name of the first author. I see the name of Dr. Hijazi with his study. which is a very nice paper to read, and encourage everyone to take a look at it. And they included it in their in this meta-analysis to get their recommendations. So overall survival rate after SBRT and this meta-analysis at three years was 57%, and at 5 years about 40%. Tumor size and region of treatment being Eastern versus Western was significantly associated with overall survival. Probably this probably related to probably the different cofactors and or confounding factors that happen in certain populations versus the other, or the nature of disease. Is it infection caused like Hep C or Hep B, or NASH cirrhosis related, or alcohol related? These factors probably have some play in this. Size, less than 3 versus more than 3 was correlated as well. Child post-core being 7 or less or more than that correlated also with this outcome, probably because of toxicity with the higher child post-core. Local control rate after SBRT was 84% at 3 years, which is an excellent outcome. Our modality is local control modality. And if we have 84% at 3 years, then this is really, really good. At 5 years, they report 82%. Again, multiple reports have multiple things, but this meta-analysis gives us these numbers. Tumor size was the only prognostic factor for local control. Size being less than 3 is better than more than 3. But even with size more than 3, we are much better than interventional radiology procedure like TACE or RFA in giving local control, even though the number here is less, but this is SBRT to SBRT. BED was not correlated, interestingly, to higher local control. This is contrast to the liver metastasis, which we will see later, where BED is of a great importance. This tells us probably that HCC is radio sensitive and can respond to doses at even 27.5 or 30 gray in 5 fractions. Interestingly, they report biliary toxicity, and RTOG 1112 has its protocol, which is also available online as open access, the full protocol for planning, dose constraints. It's a great protocol to look at if one is establishing or treating liver SBRT program. It has a constraint on the gallbladder, probably to decrease the chance of this weird and rare toxicity. What about SBRT to metastasis? So previously was all HCC. So in metastasis, there are multiple reports. In this paper, the authors report a local control that ranges really. Some people can see 71%, 72%, and 71.9, 61.2, and say SBRT is a very bad modality in treatment of liver metastasis. It doesn't give us good local control at 1 year. And then others might see other reports of 93 up to 95% and say SBRT is the best modality. This is as close as it can get to 100%. What drives this change between these data? Well, other than being different patients and different reports and all the biases that can stem from those data. Before answering that, let's see the toxicity on the right. Toxicity was acceptable, was actually very good in most of these patients. Grade 3 toxicity and higher is really low. So the change probably, in addition to all the biases, probably also comes from some our new understanding of the role of molecular biomarkers in liver SBRT. So patients with an immune genotype like NRAS or CDK12 or EBF1 mutations have lower local recurrence rates compared to those with wild type who have lower survival rates. Superior local control for lesions without KRAS mutation was at 1 year, 73 versus 42% with KRAS mutation. What if you have KRAS in addition to TP53 mutation? Then the outcome is even worse, 69% versus 20%. One might say that, you know what, KRAS and TP53 means bad disease. That's why probably patients are not having good local control. That's why probably they fail. But it's something to think about. But radiation therapy is probably used for local control in these patients. And those patients, one would think if we give them a high dose radiotherapy like SBRT, and we get good local control, they would fail and their disease would fail outside. But here, with this mutation, you have a different outcome. So this gives the thought of whether one should consider increasing the BED of radiotherapy with SBRT to those patients compared to those without. And this really requires high doses of radiation compared to HCC to get good local control, especially with those mutations. Other diseases like breast, local control at 1 year, more than 95% in this retrospective analysis. High SBRT dose at BED with alpha beta ratio of 3 associated with better progression-free survival. Molecular subtype other than ER positive, HER2 negative did better. You can see at the lower part of this diagram that BED higher than 100 had a favorable hazard ratio compared to others with less than 100. When speaking about metastasis, we should note this great sequence of MRI Primovest, an MRI sequence that uses gadoxetate disodium, commercially known as Primovest. It is hepatospecific paramagnetic gadolinium-based contrast agent used exclusively in MRI liver imaging. Its primary use is in hepatic lesion characterization. It's a great sequence to rule out other metastatic liver lesions and to characterize visible ones. So it is a good sequence. Say, for example, if we receive, for example, patients for SBRT, and we have suspicion about other lesions, or we're not really sure about other disease in the liver. We want to see if this is really limited and worth giving the SBRT or diffuse, or there are multiple lesions. This will be your most sensitive sequence, but when asking the radiologist to do this sequence, it should be noted in the request. Otherwise, they would just do the regular liver protocol MRI. What about palliation? So there was previous data from Toronto about using 20 gray in 5 fractions to whole liver. But what about comparing that to observation alone? Why to bother patients with radiation to palliate their painful HCC, typically right upper quadrant pain that is bad and irradiating to their right shoulder? Why to bother them with radiation and probable toxicity when supportive care can be enough? So this is what this trial aimed to answer. This is their randomization. They assessed pain at 1 month after radiation and at 3 months after radiation. The radiotherapy planning was very simple, simple 2-field or 3-field planning, no fancy planning, no IMRT, no VMAT, nothing like that. Patients were evaluated, simulated, planned, and treated on the same day. No requirement to contour even organs at risk in this trial, except for spinal cord, has to be contoured. Bowel was mandated to be contoured only if out of liver Dmax was at 9.5 grays or higher. Then one must contour the bowel to see if this Dmax is within the bowel or outside, just to see if there is concern of toxicity. But before considering this trial, one should look at the criteria over here of what they included. It's true they mention here child PO of less than C11. C11 patients decompensate and C10 decompensate on radiation much at low doses compared to those with B7 or A5 or A6. Most of their patients were not child PO of C. Most of them were A and B. So one should take that into note. And then they required platelet count to be at a certain limit, AST and ALT to be less than 10 times of upper normal limit. So there was improvement in pain control with this simple planning, 8 in 1, delivered only in 1 day. 67% compared to 22%. So it's a great modality that we should more and more offer to our patients with HCC or with liver metastasis that cause them pain with stretching of the liver capsule. There was also talk about this probably trending or overall survival advantage, but we're not sure really if that reached significance, and it wasn't the primary outcome for this, and it wasn't powered to test this outcome. The final publication is awaited from that group. So now going back to the original diagram. This is the 2022 most recent BCLC treatment guidelines. With all of that, we would think that radiation is probably better than most interventional radiology procedures and is a great modality for cure or for bridging to transplant or as a palliative modality. RFA is bad when you have closed vessel. You have the heat sink effect, which really decreases the effectiveness of it. TACE is limited when you have higher child PO score. TARE has a limitation of the size. And most of these modalities of interventional radiology, more than size of 3 centimeter, your local control really decreases compared to SBRT. SBRT can treat any shape. RFA gives you sphere. So you could often, those patients have failure at the rim of the RFA cavity, and then patients are referred to us to fix that, to radiation oncologists. So it's a great modality. It's really surprising not to see it being implemented. And there is a lot of talk and a lot of debate of why this happened, and a lot of arguments. You might see some of these on social media. My opinion is radiotherapy should be integrated from the beginning as either curative treatment or bridging to transplant or as palliative. Should be an option for most of those patients. Of course, patient selection is important. Dose selection is important. Good SBRT with good treatment delivery and accuracy is important to have good outcomes with as low chance of toxicity as possible. The workflow is long for those patients. Starts with simulation. One should use good setup, probably body fix, abdominal compression to decrease the chance of diaphragm movement affecting the liver. good motion management for DCT. If one would create an ITV, for example, gating at exhale or inhale. At inhale, it's great if you're close to the heart, where at exhale, it might gives you an advantage if you're close to bowel and at the lower aspect of the liver to decrease, probably decrease the Dmax there. Or tracking if CyberKnife or other modalities for tracking is available with good fiducials insertion. Also at centers where workflow is really detailed, people would use fluoroscopy to see the motion of the diaphragm before subjecting those patients to gating, for example. Supposedly, the patient is able to hold their breath for 30 seconds, but their diaphragm movements has a drift. Then this means even if they hold their breath, the diaphragm really shakes and moves. This drifts probably means they're not stable enough to go for true gating, or means probably increase in the ITV or a PTV increase in the soup-enf margins should be created. Localization and matching on day of treatment is important. This really changes based on the modality that one used for motion management, whether it was ITV based using for DCT, whether it was gating, whether it was tracking. Verification or matching on the day of treatment can be either with 3D based CBCT or even 4D based CBCT. Again, depending also on the planning modality for those patients. Contouring. So those patients, especially with HCC, this disease is defined by 3 phases: arterial, venous, and delayed venous. It will be great if patient can be simulated using triphasic liver protocol. This is really difficult to establish in radiation oncology centers with simulation and to have it as good as diagnostic quality. But if done, very helpful in the contouring process because you need all of the 3 scans to define the exact disease. However, if this is not done, for example, we don't do it here in our center. What I ask for is a recent CT scan that is a liver protocol or MRI liver protocol recent, just before the simulation or a few days after simulation, as early as you can get those close together. And then fuse them with your CT sim with contrast. Don't fuse them to bone like rigid registration, but register them to the liver. Not necessarily a true deformable registration, because that decreases the quality of the pixels of those scans, but as close as it can get, not truly deformable, but something like as good rigid as it can get to liver. One must contour also the tumor thrombus if it's there. But important to note, not bland thrombus. How to differentiate is tumor thrombus gives you characteristics similar to HCC. So it will be arterially enhancing and it will have a washout. Usually, if you have MRI simulation and do it, and then you get your T2 sequence and you fuse it with the liver, a very good fusion. Usually, disease will not be larger than T2. So T2 is usually the largest it can get when defining or contouring this HCC disease. Probably if using triphasic CT scan and triphasic liver, you will get a contour that's smaller even than the T2. Metastases have different characterization depending on the disease. RCC, for example, will have vascularity and will have probably different characterization from metastasis from colorectal cancer, which will probably be maybe hypo-enhancing on venous phase. It is great if radiologist is around when contouring these to help also defining the disease on CT SIM. CTV is same as GTV in most times of treating those. However, one must note that if patient has received RFA or TACE and has a cavity from those treatments and has a disease at the rim of the cavity, CTV margin should be added to the cavity plus the disease up to 2 millimeters, 1 to 2, just to be able not to miss those rim malignant cells at the rim of those cavities. If treating intrahepatic cholangiocarcinoma, the margin is even increased up to 2 centimeters added, with probably simultaneous integrated boost sort of SBRT delivered. So maybe high dose to cholangio, it needs really high doses, maybe up to 50 grays, if that can be delivered or higher. And to the larger CTV, probably smaller dose, maybe 35 grays. It's a really sneaky disease and goes through the ductules and should be treated aggressively with as high radiation as possible with patient factors with a CTV. ITV, if not gating and treating based on 4D CT should be created. Rarely, but sometimes needed with gating if slight motion drift is noted at simulation fluoroscopy. This is if simulation fluoroscopy is done at the center. PTV is institution and setup dependent. Most people would use 5 millimeters though. If you have slight uncertainty, one might increase the margin at SOUP and maybe to 7 millimeters. It's important to contour the normal organs at risk very well. This is a very good consensus guideline from this group, highly quoted. And they define the locations of those organs very well. Where does the duodenum start? Where does it end? How to contour it? The bile duct, common bile duct, the veins, really all organs in the abdominal cavity, even the segments of the liver, coronally and axially. It's a nice publication to see and to read. It's not too long as well and has multiple pictures. When someone using tracking as a modality, it's important really to know where to place those fiducials. This is a guideline that comes from Accuray to guide placement of those fiducials. Maybe sitting with interventional radiologists just to tell them about this and where to put those fiducials, at what angles, at what locations, what distance from the disease, probably helps a lot in not failing to use those fiducials. We recently had fiducials inserted. Unfortunately, one of them wasn't at favorable location, and we had to treat the patient instead of CyberKnife to LINAC-based SBRT. Thank you so much for this session, attending this session, and for hearing.
Thank you, Dr. Khalid, for this comprehensive review of the topic. It's very interesting to see how things changed. And okay, so let's open the floor for questions. You could either write in the chat or you could raise your hand and they'll give you the host to speak.
I see Dr. Abdulaziz Al-Hamad maybe raise his hand.
هلا وسهلا.
وعليكم السلام ورحمة الله وبركاته.
Dr. Abdulaziz, maybe you are muted now.
ايه الصوت واضح.
Thank you very much, Dr. Khalid, for this comprehensive and very well updated presentation about liver disease. Actually, what I would like to say, it's more comment than it is question. In the first decade of this millennium, liver cancer, HCC or metastasis were very promising for radiotherapy with the era of starting the adaptive radiotherapy trials and the SBRT. And this is one of the areas where the organization, with scientific organization, sometimes could fail to face the big giant companies, pharmaceutical. Because the recruitment, as you mentioned, Khalid, in many trials was very weak and low, because pharmaceutical companies was also interested to try many target and immunotherapy. So this is one area where we learn some moral lessons sometimes, and hopefully something gonna change in the future, because I think very effective treatment like SBRT or radiotherapy in general, we didn't given that much chance while trying a lot of medication, with all respect. That's all my comment, and thank you again, Dr. Khalid, for this nice discussion.
No, thank you so much for raising this important point and this comment. It's true. Pharmaceutical companies always, when they have all the money and they direct it to their advantage. Yeah, thank you so much.
دكتور ماجد.
Assalamu alaikum.
Assalamu alaikum.
Thank you so much, Dr. Khalid. Excellent talk. I can see your effort, and I also can see your collaboration with Dr. Laura Dawson, who's a pioneer in this aspect in University of Toronto. A couple of things. You mentioned certain things that at least I am not familiar with, which is the simulation fluoroscopy with diaphragmatic drift. I don't think it was clear to me, if you could elaborate. And also what you mentioned about contouring the tumor thrombus versus a bland thrombus. Yeah, we're all learning. It's a new term that I hear. If you could elaborate on these two things, the diaphragmatic drift and the bland thrombus. And also, I saw in the case report that you have some experience in MRI-guided radiation therapy, and I would like to see know what you think of the advantage of having MRI-guided and in places where there is no MRI-guided radiation therapy. So diaphragmatic drift, bland thrombus, and MRI-guided radiation therapy.
Yeah, no, thank you. Great questions and great points. With drift, what it basically means is, let's say patient is planned to receive gating-based radiotherapy, let's say in full inhale or full exhale. Let's say, for example, as a DIBH, sort of similar technique. Fluoroscopy is done at some major centers just to see how the diaphragm moves. You have MV-based fluoroscopy under LINAC to assess the movement of the diaphragm, and as such, you could say of the liver. Is it stable, for example, let's say like this, or is it a bit shaky, like diaphragm moves unintentionally by the patient up and down, and it moves the liver with it. It has a certain number that one should see, for example, if this is reproducible or not, which means if the diaphragm drifts and moves a lot and moves the liver with that direction and intentionally by the patient while the patient is holding their breath or at exhale, probably at time of treatment with no ITV, you will miss your target. Meaning if it goes up and down and then you miss the upper part or the lower part or the part where the liver really drifts to, for example, it is acceptable up to small certain limit, but above that, one probably should use maybe an ITV-based radiotherapy planning, like with 4D CT, or probably should add an extra PTV on the patient while being gated. Of course, given that the drift is really limited. Most centers don't do that and don't consider it, but if one would be very detailed about the SBRT process, then this is something to consider. The other thing about tumor thrombus versus bland thrombus. Bland thrombus is the usual thrombus that can happen really anywhere in the body. A blood clot that's not malignant, just because patient have some thrombosis or more prone to thrombosis due to risk factors or other things. Where tumor thrombus is, it's the cancer itself in the vessel causing a thrombus rather than just invasion of the vessel. The difference between them in imaging is thrombus is just the blood clot that will not enhance on the arterial phase. It will not wash out on the venous phase. It doesn't have any tumor cells. Where tumor thrombus would give you similar picture, similar to HCC. It will arterially enhance. It will wash out on venous and delayed venous phases. So it's important to include it in treatment planning and contouring because it does have cancer cells in it. But one should note also with the previously mentioned reports that having a tumor thrombus probably gives extra chance of toxicity, something to take into consideration, but doesn't prevent us from delivering SBRT. MR-Linac is really great in treatment of SBRT in general, especially abdomen SBRT. For example, in those patients with HCC, some of them have ascites, which is something that's included in the child-post score, either to increase the score or to decrease it. Supposedly, the patient has ascites and it's severe, and he has ascitic tab, let's say, every 2 weeks. Otherwise, fluid accumulates in the abdominal cavity. And we bring the patient, let's say, on day one after the ascitic tab. Planning process, let's say, at best, maybe takes a week for the contouring, planning, calculation, QA, and reviewing at rounds. Then the patient comes the next week, 1 week away or 1 week from the ascitic tab. The abdominal cavity has fluid. The separation of the patient is changed. Dose calculation is changed completely. With MR-Linac, you get a quick MR scan, well, not as good quality as the diagnostic, but different sequences. And then with just small changes in the contouring or adjusting the contour at each fraction with regards to the target and to the organs at risk. Not all organs at risk are recontoured or remodified, but only those that are about 2 to 3 centimeters from the high dose of the target. Then the program itself or the integrated treatment planning system gives you a plan that takes into account the changes in the patient, the changes of the location of the organs at risk. Say that duodenum is closed and you're afraid of giving the duodenum very high Dmax. You have uncertainty with other modalities, but with MR-Linac based treatment, you know where the duodenum is in each fraction. So you can increase your dose with lower risk. It's great in pancreas, where duodenum is really close. It's probably like the best modality in escalating the dose to pancreas, maybe up to 40 grays in 5 fractions, which is a dose that's very difficult or maybe probably unsafe to give using Linac-based radiotherapy to the pancreas. What is really a good advantage of MR-Linac is, for example, if we have two targets in the liver at different locations. Liver moves like this. It like swims in the abdomen. It's not just up and down. While the patient is breathing or while the patient is being gated, using the MR-Linac, it sees both locations. So supposedly one location went slightly higher than the other or lower than the other. It accommodates for those changes, and it accommodates for the delivery and the plan optimization. I recently saw a video. I think I have it now on Twitter from Parsity from California, who treated the patient 1 week or 2 weeks ago with this. And it really shows how nice it is to treat both at slightly different locations in the liver with MR-Linac, without missing and without needing to increase your PTV to account for this movement. I can probably open it if that's okay.
Thank you so much. It's excellent, really answers, and it's very satisfying. Thank you so much.
Thank you.
Okay, thank you, Dr. Khalid. So we have a question in the chat from Dr. Khalid Khalil. Is there any evidence for improving portal circulation following inclusion of malignant thrombus or part of the thrombus in the SBRT for HCC?
Well, there is anecdotal evidence that I'm aware of that HCC responds to radiotherapy and to SBRT. And when you treat this tumor thrombus that contains cancer cells, you're decreasing its size, and probably that would improve the portal circulation. Is there specific data reporting the improvement itself in circulation? I'm limited in that, honestly. I don't know. There must be something. There's probably something, but I'm not aware of it.
Okay, thank you, Dr. Khalid. Do you have any further questions?
If you allow me another question, you know, is it possible? Can I ask another question, please?
Sure, go ahead.
Dr. Khalid, following up after SBRT, it's always a problem, I believe, in other sites, you know, like lung, whatever, because of the fibrosis and the reaction that happens. What happens after SBRT, and what's your strategy for follow-up and assessing response in liver?
Typically, those patients would be followed if they went through their SBRT well, and they're not, say, they are child of A, and they're not expected to have really high chance of side effects. Probably follow up at 3 months intervals for the first 2 years is reasonable, with CT liver protocol at each time, or MRI liver protocol. Just like choosing one and going with it is probably a good idea. I say the advantage of CT is that the acquisition is really faster, so you don't have a lot of issues with breathing artifact that you can see sometimes on MRI. Probably the 3 years after that, every 4 to 6 months with similar imaging being ordered, and if patients will be followed after that on 1 year's intervals. Usually the effect of SBRT is seen probably at not the full response is seen at 3 months, probably 6 to 9 months. Sometimes we see the response, but as long as the mass is not increasing in size, as long as its characteristics are going away slightly, like the arterial enhancement, the venous washout, then things we know are moving in the right direction. Also, alpha-fetoprotein is very important thing to include in those patients follow-up. It should trend down with treatment response. Some of them don't have an upfront alpha-fetoprotein that is high, and so then the role of alpha-fetoprotein is probably not as well as established as the others, but could be ordered as well. And those with intrahepatic cholangio, important to order the CA 19-9 upfront before treatment to establish baseline, and then afterwards as well.
Yeah, I mean, I mentioned this because our colleagues in medical oncology usually use the RECIST criteria, which depends on size or depends on certain features. And we might not actually follow the same aspect. We have, as you have mentioned, sometimes the response might be delayed. So some people might order a premature imaging looking for a magical effect for this while it takes some time. Thank you so much.
Thank you.
And Dr. Khalid, we have another question from Dr. Khalid in the chat. What's the best time for usage of SBRT for treating liver mets as a consolidation following systemic treatment with expected low avidity on PET or active lesions, either upfront or on progression? So whether you wait till the disease is progressed to treat with SBRT or upfront when the lesions is seen.
I would say if you have limited disease, smaller in size and smaller in number, it's probably the best time to treat with SBRT. We know with larger size lesions, especially those are more than 3 centimeters, the control is less. The local control is less. So smaller size is the time to treat. Smaller number of lesions is the time to treat. And also at early time, the liver, the chance of liver to decompensate is also less because the patient liver function is probably better at early time disease. Now, when to treat an oligoprogression, oligometastasis, usually the followed thing with oligometastasis is the oligometastasis data, like in COMET or others. When the oligoprogression, when really there is a mixed response in the patient and only 1 or 2 lesions are increasing in size compared to the others, you would wonder if there is different mutations in those 1 or 2 lesions. And it's probably beneficial to treat those aggressively just to try to decrease the chances of those focal spots of increasing size, metastasis, mutations going elsewhere in the body and making the disease more resistant. There is a recent trial, I think 1 or 2 months ago. Not really, I forgot really the name of that trial. It shows really benefit in progression-free survival of those patients who are aggressively.
Okay, thank you, Dr. Khalid, for this comprehensive view and taking time to answer all of these questions. So the question about re-irradiation of lesions treated already and let's say in the between 6 months to a year. What's your thought on this? Yeah.
Yeah. So if re-irradiation is considered reviewing previous plan is probably a good idea to see how much the normal liver received, and taking that into consideration into the future plan, similar to any retreatment really anywhere else in the body. Probably the difference with those HCC patients is, with time, those patients' child post score increases. So say if they were treated 1 or 2 years ago when their child score was A5, and they're treated now with a higher child post score, because their disease probably, if they recurred, probably there is some sort of small decompensation, let's say B7 or B8. Then one should not only consider the previous irradiation, but the increase in the poor functionality of the liver and the increase in the child post score.
Okay, thank you so much. Okay, well, if there is no further question, thank you, Dr. Khalid, for this comprehensive review. It's very nice to shed a light on this, emerging topics, and raise the awareness among the radiation oncologists first and themselves, and then to the other member of the tumor board to get more chance of our patient to receive this excellent treatment. And thank you to the SARO for choosing this topic to be a topic of discussion for tonight. Thank you all, and have a good night.
Thank you so much all. Thank you so much.